knocking down a gene affected elsewhere. But but as a clinician, I can tell you these are not going to be easy things to sell. Going down and getting a renal artery injection at risk of thrombosis and so forth. The ureter upstream is another issue. Maybe that's a bit more easier, but I think therapies that are going to be delivered systemically or through the skin or something like that are going to be much easier to sell, in my opinion, at least thinking of patients. But obviously, if it's a debilitating, horrible disease or cancer, sometimes when you're dying, patients don't care about these kind of things. But for routine things, I think invasive delivery always will never be as good as more easy systemic or sub-Q or some kind of delivery, or even intranasal or oral,
Right. Understood, and we get that, and I think that's what. So I take your points about the localized and considering these are viruses that are potentially, permanently altering the cell. That might be, potentially useful here. So that's sort of some of the questions we had. I think you already sort of alluded to it, right? So IV is going to be preferred. So something that you can administer IV and it could, get into the kidney would be preferred by patients. So two questions about those three routes of administration: renal artery injection, intraparenchymal injection, retrograde injection. So which one's the most invasive of those three?
I think intra-arterial is probably the most dangerous in my opinion, and followed by intrarenal, because the thing with the intra-arterial, there's always a risk of, first of all, you have to, I guess you could do it subcutaneously as well and open, but most likely subcutaneous. Whenever you enter the artery, there's always a risk of thrombosis, in which case you could lose the whole kidney. Whereas intraparenchymal, we do biopsies all the time. We do biopsies and transplant native kidneys here, which we perform and I perform. There's always a risk of bleeding and so forth. We're not taking a core. We're just injecting with a tiny needle. So I think the risk is probably a lot less than a biopsy. And so you could argue that's a lot less than arterial. And then I think the going through the bladder and the retrograde, probably the least invasive, when people have cystoscopies all the time. The advantage of, I suppose, theoretically coming through the retrograde approach is that you can directly, more efficiently deliver to the tubular cell. So if it's a tubular cell problem, a ciliopathy or something like that, you could deliver it through that end, of course. But people generally don't like it. But I think in terms of risk, I think that would be the least. Intrarenal number 2, and worst would be intra-arterial, in my opinion.
Thank you. That's really helpful. So would I get the sort of the different invasiveness / risk, safety risk. So if you looked at, if we just thought about, I guess, the retrograde route, right? So if you're thinking about patients with any of those diseases we mentioned, AKI, diabetic nephropathy, CKD, outport, ADP, KD, AGA, nephropathy, etc., kidney transplant rejection, lupus nephritis, C3 nephritis. So you mentioned the epithelial cells of the tubules, right? So that might. Is it expected that would be more efficient to reach those types of cells, those cell types?
For sure. I think for the retrograde approach, for sure, it'd be tubular cells. Now, I guess you could theoretically, depending how far you get the virus, you could hit the parietal epithelial cells as well, meaning the podocytes, because they're on the other side. So you could deliver it there. You could deliver it to the tubules and any part of the tubules, and of course the urinary tract as well. That would be an obvious one. Although we don't deal with a lot of those myself because I'm not a urologist, but so I guess the parietal epithelium, which is the podocyte, you could deliver it to. You could deliver it to the tubular cells, any part of the tubular epithelium. The problem with injecting intravenous always is concern because you have to cross the tubular basement membrane in order to get into the tubular side, of course. Now there is lots of evidence now, new evidence showing that there's constant sampling of the tubular epithelium by macrophages, so even tubular epithelial cells transferring material from the urinary side, meaning the tubule lumen, into the bloodstream. There was a recent paper published in Clinical Investigation showing that during contrast-induced nephropathy, macrophages are collecting samples from inside the tubule and so basically, I think that even if you deliver it retrograde, it will also have access to the other side of the tubular basement membrane. So it will not be just. It'll be naive to think you'll be limiting it just to the tubular epithelium, but that would be the obvious target. And podocytes.
Yes. Doctor, can you please just explain that a little more for me?
Sure.
So you mentioned it could potentially get past the tubular basement membrane into what?
So let me give you the gut as examples because people mostly know about this. So for example, in the gut, the immune system is constantly surveying the gut. Even though there's epithelial barrier, basement membrane, and then the interstitium, immune cells inside the body are constantly sampling the gut. And we know this whole microbiome interactions that most people are aware of. The same way in the kidney now, and it's not just one paper, there's multiple papers showing that there's constant sampling of the tubular lumen proteins, for example. It could be sugars, it could be mostly amino acids or proteins, are sampled basically across the tubular lumen into the past the epithelial cell to immune cells inside the interstitium of the kidney. The most well-studied, I would say, is macrophages, maybe dendritic cells. And so they have access to the tubular lumen, and some of the mechanisms could be in between the tight junctions, which are not clear now. But also the tubular cells seem to be taking it up and passing it, basically like passing a football from inside the lumen to the other side to macrophages. So that was a recent paper published in JCI. I think it was the last couple of months ago, where they showed in contrast-induced nephropathy, the contrast agent is being passed across the tubular lumen into the two macrophages, and then it gets them inflamed. So what I'm saying is, let's say you deliver viruses, it will be naive to think that viruses, whole virus even, may not be able to get access to the other side, either through passive or active mechanisms.
Right.
And the split cells be aiding it as well. So
you're saying, am I understanding you that ideally you wouldn't want the viruses to get past that?
No. I'm not saying that. It all depends on whether you want it to get across or not. So let's say your goal was to keep it specifically into the tubules because it's, let's say, horrendous if you get it into the immune system or somewhere else. That could be dangerous. But if you're not too worried, you're just doing it just because you want to focus on the kidney, but if it gets out a bit, you're not worried, then I wouldn't be concerned. But if it's something that you don't want affecting other parts of the body, especially systemically, it would be naive to think that there will be no systemic access when you give it retrograde. But if you're not worried about it, then I think the whole idea would be just to target the kidney by giving it retrograde. Then I wouldn't be concerned.
Okay, I see.
So I understand. I think I know where you're coming from. I suppose you may be delivering it into kidney specifically so you don't elicit an immune response. Is that one of the reasons you're thinking about it, or is it more for delivery?
I think the primary concern is delivery, and I think the secondary concern is what you're getting at is that some of these pathways, you would want to only hit certain. You would only want to transduce kidney cells and not liver cells, for example. Right?
Correct. In that case, yes. But also immunology-wise, you may still get an immune response. Even though you deliver it in the tubules, it will be naive to think you will not get an immune response. Some people might think, you know what, we're going to give it retrograde in the tubules, the immune system will not see it, therefore I will not get an antiviral immune response, right? Because you're delivering it inside and I don't think that's true. You will probably get an immune response, even though you're hitting it through the urethra and ureter. So.
Got it. Okay, thank you. So that's the third issue with the immune response. So basically, the retrograde, you can get to the epithelial cells, you can deliver it. You would likely to still induce an immune response like you would through systemic administration, but it's less likely to reach other organs. Is that true or no? I mean,
I think it's much less like if you give it in the kidney, it's much less likely to get in there. But But if you give it through the artery, for example, some of it will be going back to the body. So I think artery-wise, you're more likely to deliver to the rest of the body. Then, of course, retrograde would be less. Right. But of course, retrograde will have the least amount of contamination of the rest of the body. But all I'm saying is don't assume it's no delivery into the system. There will be some delivery into the system, even if you go retrograde.
Okay, so there'll be some, but there'll be less than the artery.
Yes.
True. Okay, and what about the into the parenchyma for the kidney?
So into the parenchyma, I think that's the only reason to do that is you want to try to deliver a higher concentration locally. For sure, it will access the immune system, and it may go systemically a little bit, but definitely it's better than giving it IV. If you give it IV, it's going everywhere.